it will be in the same slide set
Because the cardio perspective will be
by Dr. Anurag Sharma.
doctor. Yeah, yeah. Doctor will share.
So in between you talk to sir and then make his availability also, right?
Sir told that 7:15 he will be live.
Sure.
Okay,
Okay,
so
so I
you
can start.
can. Yeah, I will give a small introduction of you both, sir, and about the topic. Then I will hand over the session to you. Then you start the presentation.
Okay.
Yeah. After we go live. Yeah. Can you stop sharing, sir, if you don't mind?
Yeah.
Yeah. Thank you.
Sorry, sir.
Yeah.
We are live, sir.
Okay, thank you. Good evening and welcome to the expert crosstalk on the Empagliflozin, multi-mechanisms, multi-indication, multi-benefits. As we already knew that ESC 2020 was memorable with a pathbreaking clinical data presented from multiple global trials. This program is designed with the objective of dialogue between two different specialities, that is cardiology and endocrinology, which will bring upon two different ways to address the complexities of the clinical cases in heart failure. So according to Emperor Achieve trial, does SGLT2 inhibitor may be considered as an important drug for heart failure? To get the answer, let me introduce today's speakers. Today's speakers are Dr. Anurag Sharma and Dr. Rajat Gupta, and I will moderate Dr. Shavi. Dr. Rajat Gupta is a consultant endocrinologist at Alchemist Hospital, Panchkula. Dr. Rajat has various publications in national and international journals and wrote many chapters in endocrine textbooks. He has delivered many lectures in national and international symposium and actively participated in various campaigns on public awareness and also a recipient of the prestigious A.V. Gandhi Award for research work on vitamin D. Welcome Dr. Rajat in this expert program. Our next speaker is Dr. Anurag Sharma. Dr. Anurag is a director, Oja Super Specialty Hospital at Panchkula. Dr. Anurag has several national and international publications in his credit and is also co-investigator in several trial registry. He has received several awards till date. I welcome Dr. Anurag in this expert web talk and I'm handing the session to Dr. Rajat to start with the presentation. Thank you.
Thank you, Shavik. I'm just sharing my screen here. So good evening, everyone. So today I'm going to discuss very interesting cardio and diabetic perspective. So endocrine part I'll be sharing and cardio part Dr. Anurag Sharma will be sharing. So empagliflozin, as we all know, it's a drug which covers both the diabetes management as well as now it is more and more evident that it has got a lot of impact in management of cardiac disease as well, both in diabetics as well as in non-diabetics. So multiple mechanisms of action of this drug, meaning thereby multiple indications and then multiple benefits. So this is the SGLT2 inhibitor modulate a range of factors related to diabetes based on clinical and mechanistic studies. The most important is obviously decrease in the glucose levels by causing glucose urea and then in turn leading to a decrease in insulin resistance. Also, it has a lot of effect on weight reduction and decrease in the visceral adiposity because of loss of calories it results in because of glycosuria. Then decrease in blood pressure, decrease in arterial stiffness. Indirectly, it leads to reduction in albuminuria. By mechanistic changes, it brings about in renal dynamics, restoration of tubuloglomerular feedback, decreasing the hyperfiltration injury to the nephron, and thereby decreasing the albuminuria as well. It leads to reduction in uric acid, which is also now considered as a surrogate marker for cardiovascular disease, leads to some, though not significant, but some changes on LDL and HDL levels, and decrease in sympathetic nervous system activity as well. Now, there are multiple benefits of SGLT2 inhibitor as we can see in this slide. ACE and ARBs, ARNs, and beta blockers and MRAs, diuretics, and then SGLT2 inhibitors. ACRBs, ANI, MRAs, diuretics, and SGLT2 inhibitors all lead to natriuresis. Then kidney functions improvement and cardiorenal physiology improvement is brought about by ACRBs, ARNIs, and SGLT2 inhibitors. Decrease in preload, afterload, and left ventricular wall stress is reduced by all the drugs mentioned here, not by the diuretics directly. And interstitial edema is reduced by diuretics and SGLT2 inhibitors. So all the drugs which benefit in heart failure, all those benefits are seen by additional single molecule which is SGLT2 inhibitors, which have now place in the management of heart failure, though not as a primary drug but as an add-on drug after ACRBs and ARNIs, definitely beta blockers, MRAs, all those. So there have been now four SGLT2 inhibitors, especially which are available in India: DAPA, then Remo, Canagliflozin, and Empagliflozin. As I just mentioned, the main mode of action of SGLT2 inhibitors is to stop the reabsorption of glucose in the proximal convoluted tubule in the kidney and leads to glycosuria, thereby leading to loss of calories, weight reduction, and other hemodynamic changes it brings about through this mechanism. These are the three important molecules which have basically available maximum data, cardiovascular outcome trials as well as other renal outcome trials, EMPA, DAPA, and CANA. The therapeutic dose of empagliflozin is 10 milligram and 25 milligram. DAPA usually we give in 10 milligram dosage, and CANA is 100, and sometimes we use 300 also. All the drugs are given once a day. Peak plasma concentration is about 1.5 to 2 hours. Absorption is close to 70 to 80%. Metabolism is mainly primarily glucuronization, no active metabolites. Elimination is dual, mostly by hepatic and renal route. Selectivity is there with SGLT1, and glucose excretion is about 70 to 80 grams per day. It indicates basically how much calories are being lost through kidneys when we use SGLT2 inhibitors. That amounts to about 300 to 400 calories per day. Empagliflozin, if we talk about in particular, pooled phase 3 placebo corrected changes in baseline A1C. As we can see here, 10 milligram and 25 milligram is about 0.6, 0.68%. And then as a monotherapy, it depends on the baseline A1C though, but most of the studies have shown HbA1c reduction of about 0.8 to 1%. Similarly, if we talk about body weight reduction, it varies from different studies to about 3 kgs and 4 kgs, but in practical, we have seen weight reduction of up to 8 kgs and 10 kgs as well. Similarly, changes in systolic blood pressure to the tune of 4 to 5 millimeter of mercury in various studies, whether we use it as a placebo, as add-on drug, or whether you use it as a single drug. This is a very interesting slide which I am presenting to you. This is a basically 12-week ambulatory blood pressure monitoring study of EMPA in patients of type 2 diabetes, and their systolic blood pressure was measured early. And you can see here baseline. This is a placebo, EMPA 10 and EMPA 25, and the end of 25 weeks, 12 weeks. So this is the placebo, and this is the reduction with EMPA 10 and 25. So you can see for most of the day, barring last 4 hours or 6 hours, this is the dose given. Most of the day, it is reduced by about 5 to 8 millimeter of mercury in comparison to the placebo at the end of 12 weeks. And this important thing is, this reduction in BP was not associated with reflex tachycardia. Sometimes we see with other drugs. So very important, very extra glycemic benefit seen with empagliflozin. Similarly, diastolic blood pressure reduction is also there to the tune of 4 to 5 millimeter of mercury at the end of 12 weeks compared to the placebo. There are insignificant effect of empagliflozin on lipids. There is some reduction in LDL, non-significant, some increase in HDL level and some reduction in triglyceride level, though not very significant. This is the SGLT2 on glucose control, body weight, and systolic blood pressure. This is a busy slide, but all I wanted to show here is this reduction is about 30 milligram per deciliter by about fasting. Body weight reduction about 3 to 4 kgs, and systolic blood pressure reduction is about 4 to 5 millimeter of mercury, depending upon the drug we use as a monotherapy or add-on therapy. So, thus, pool safety and tolerability data, summary of adverse events, as you can see here more clearly. Patient with any adverse effect, this is the placebo, this is EMPA 10 and 25. So, no much difference between the patients who received placebo versus empagliflozin. Patient with adverse effects leading to discontinuation, again, no difference. Patient with serious adverse events, again, no difference. So, in totality, it was found that EMPA is as safe as placebo, meaning thereby no additional adverse event leading on to discontinuation or no serious side effect. This is the pooled analysis of all the side effects which was evaluated: UTI, pyelonephritis, urosepsis, genital mycotic infection, volume depletion, and other side effects. Only genital mycotic infections are more in patients who are on empagliflozin compared to the placebo. You can see here 1.1, 4.7%, and 5.6%. All other side effects are comparable to the placebo. This is the EMPA-REG trial. We are all aware, the landmark trial, cardiovascular outcome trial, done with empagliflozin versus placebo in patients of type 2 diabetes, and they wanted to know whether there was improvement in 3-point MACE versus placebo. Also, there were renal outcome of this EMPA-REG trial, which I am showing in this slide. So you can see here, EMPA versus placebo, incident of worsening nephropathy much less, hazard ratio 0.61, that's 39% relative risk reduction with empagliflozin, progression to macroalbuminuria, again significant reduction, and composite renal outcome, again significant reduction. So in addition to glycemic benefit, in addition to cardiovascular benefit, there are a lot of renal benefits with empagliflozin compared to the placebo, as seen in this EMPA-REG trial. Patients of type 2 diabetes with high cardiovascular risk, empagliflozin given in addition to standard of care, reduced heart failure, hospitalization, or CV death, with a consistent benefit observed in both with or without heart failure at the baseline. This is the EMPA-REG trial outcome which I was talking about, 3-point MACE. So 3-point MACE was clearly in favor of empagliflozin compared to the placebo with 14% relative risk reduction. And look at this CV death, 38% reduction seen with empagliflozin compared to the placebo. There are other CVOTs also with dapagliflozin and canagliflozin, but none of the SGLT2 inhibitor has shown this much CV death reduction as seen by empagliflozin in EMPA-REG trial. So, post-hoc analysis of EMPA-REG outcome, how early after treatment initiation these cardiovascular benefits start to happen. This is the post-hoc analysis, and it was shown that risk in empagliflozin reduction, risk reduction with empagliflozin versus placebo reached significant at day 17. As early as day 17, there was reduction in hospitalization for heart failure. Quite early separation of curves compared to the placebo. And day 27 for cardiovascular death or HHF, as you can see here, day 27. So the benefit starts very early. When you start patient on empagliflozin, the risk for HHF or HHF and cardiovascular death put together, the risk reduction happens very early, within 2 weeks, within 4 weeks. 17 days for HHF, 27 days for combined CV death and HHF, and 59 days for CV death. So very early benefit patient gets whenever patient is started on empagliflozin in terms of hospitalization for heart failure and HHF and CV death as early as 17 days and 27 days. This is the EMPRISE trial, which is real world evidence. And in this, empagliflozin was compared with DPP4 inhibitors. And it was found that patients on empagliflozin had, this is a hazard ratio, 0.42 compared to the DPP4 inhibitors. So almost 60% relative risk reduction once patient was given empagliflozin compared to the DPP-4 inhibitor. Though it is a real-world evidence, but it goes as per results shown in cardiovascular outcome trial of Empareg. Similarly, all-cause mortality also reduced by about 50%. Again, DPP-4 inhibitors all put together versus empagliflozin. So you can see here number of events 8.3 per thousand and 15.9 per thousand, and this hazard ratio 0.52. The relative risk reduction is about 48%. So the real world evidence suggested the same thing which was seen in CBOT of empagliflozin in EMPA-REG trial. So cardiovascular safety trials are being conducted for each compound with a new class of drugs. As you can see here, the list is exhaustive. For DPP-4 inhibitor, we have Severtimi, Examin, Tacos, and then for SGLT2 inhibitor, we have EMPA-REG, Canvas, Credence, and now with ertugliflozin, we have Vertis trial. And most of the results are out already. And then GLP-1, we have LEADER trial, Sustain 6, Excel trial. So all these studies have shown that these SGLT2 inhibitors, there is one unanimity with all SGLT2 inhibitors. Vertis trial with ertugliflozin did not show reduction in 3-point MACE, but it also showed reduction in HHF. So all the SGLT2 inhibitors, they have reduction in hospitalization for heart failure as a class effect, but their effect on 3-point MACE are little different for empagliflozin, different for canagliflozin, DAPA, and also for ertugliflozin. So guidelines now suggest that patients who is on metformin, and then if he is diabetic patient on metformin, even if HbA1c is controlled and patient is at a very high risk for cardiovascular disease or having underlying cardiovascular disease, should be escalated only to SGLT2 inhibitors or GLP-1 receptor analogs, because so much benefit has been seen here in various CVOTs in terms of 3-point MACE reduction or HHF reduction. But if patient is on not on metformin and patient has underlying cardiovascular disease or diabetes diagnosed for the first time, then for the first time, any guidelines have suggested don't start metformin, give straightway either SGLT2 inhibitors or GLP-1 receptor analog, because the benefits of these molecules is glycemic benefit and also extra glycemic benefit in terms of uh, risk reduction for 3-point MACE and HHF. Also, there are other kidney benefits also. So I stop my presentation here. Thank you very much. And now I invite Dr. Anurag Sharma for his cardiologist perspective. I'm stopping my this slide sharing from my desktop.
Yes, thank you, Dr. Rajat. Dr. Anurag, you can start the presentation.
Hello, Rajat. How are you?
Good evening, sir. I'm fine, sir. Thank you.
Good, good. Nice to see you here. Just we'll discuss this later on.
Yes.
Some question answer sessions are there. So should I start my slides? More or less, I was seeing that the slides are same.
Yes, sir. It's you can start the presentation.
Okay. So share screen. And, okay. Now, can you see that my screen?
Yes, sir.
Okay. So should I go to the cardiology perspective?
Yes, sir. Yes.
Because this is all the same with what I have already. I actually just came when he was on this slide. So this is all the same thing which we are repeating here.
So this is endocrine part, and you start with cardiologist perspective. Sir.
Right, you're right. Endo is this cardiologist perspective. Okay. So coming to this drug's efficacy, all of you know that SGLT2 inhibitors are new drugs basically for treating diabetes patients. And when the first trial came, that Empareg, and it showed very spectacular responses as far as there was a concern with the heart failure hospitalization and cardiac mortality. So then the investigation was started, and actually the real mechanism At that time, it was not known that why this drug is doing so much good. So then other drugs also came, like Canvas, and other trials also came, and they have also shown benefit in these patients. So I think this is a good drug to start in these patients. And if you look at cardiorenal benefits of these drugs, and it is across the class. I mean to say, this whole class is getting into this benefit, like DAPA, CANA, and we have good trials. So hospitalization for heart failure, even CV death, and kidney outcomes. So I am also very much excited about the kidney outcome about this drug, and I would like to share you with one very good case, which recently I actually wanted to show this case. This case was having a young patient of heart failure, and we started him on all the drugs of Vimada and everything. But unfortunately, his creatinine started going increased, like I mean to say, started increasing. So we were not very happy that what should we do. So then what I did is, then I he was not having any diabetes or something. So then I started this drug, empagliflozin, in this patient. And after that, I saw that the creatinine also has gone down, and maybe it has gone down after stopping this Weimar and all these things, but he's getting better, and his heart failure symptoms are also better, because we were not able to give the the drug of choice, I would say Arni. And it was very good case, because after the DAPA HF and EMPA reduced, this drug, this latest trial Emperor reduced, I think I was very happy. This is one latest patient I had seen 2 months back, and now I saw him, and I just compared his renal functions. So just reiterating the point that despite that patient may not have diabetes, also this drug is now good because of the two trials. Because this will not lead to hypoglycemia, because the sugar, if it is not filtered, then obviously patient will not go into hypoglycemia. Only thing is, we just need to maybe see more of such cases, and more follow-up is required. So if you look at EMPA-REG outcome trial, cardiovascular outcome and death from any cause. So primary outcome 3-point MACE. The blue one is the empagliflozin, and the placebo is the the brownish dark brown. So you can see that the after 12 months it starts decreasing. After 6 months only, there is a difference in the event rate, MACE, and hazard ratio is 0.86. Even death from any cause is 0.68 hazard ratio, and hospitalization, heart failure, and CV death is less. So this is a good drug as far as the cardiovascular outcomes of these patients are concerned. And if you look at the high heart rate of heart failure in patient with diabetes over 30 years of follow-up, we all know that diabetes, without even causing coronary artery disease, even MI, there's a separate entity known as diabetic cardiomyopathy. And if you look at the heart failure patients, like 100 patients, out of them, around 50% will be diabetic cardiomyopathy, where obviously heart failure is the one of the main thing, and there's no coronary artery disease. So even in this, you can see that the risk ratio, and women have more heart failure, that we all know. So there's heart failure is more common outcome than MI, stroke, and death in diabetes mellitus trials, like LIFE, RENAL, and IDNT, all these trials. So if you look at now, this is just to compare that whether all these endpoints like myocardial infarction and event rates, heart failure, whether they're related to good intensive control of the diabetes or not. Yes, they are. They're all related. It favors more intensive control. Only the ACCORD trial had not shown much difference between these two, but otherwise all the trials have shown that this advanced ACCORD trial had shown a decrease in the MI, but hospital for heart failure it has not shown. But otherwise, all the other trials have shown this. And if you look at the other drugs like sulfonylurea's UKPDS trial, and insulin has no much benefit. Thiazolidine diones has increased, but GLP-1 is beneficial, and DPP-4 is just neutral for heart failure. But if you look at EMPA-REG or other, maybe you can see the other drugs, they have only written EMPA-REG. But if you look at other SGLT2, then definitely hazard ratio is much better as far as the heart failure is concerned. So evidence for benefit of SGLT2 inhibitors on heart failure risk in patients with diabetes. So this is again EMPA-REG trial only, same which we have shown that heart failure outcomes in clinical trials in patients with diabetes as compared to placebo has a ratio of 0.65, and multiple pathophysiological aspects has been known: improved kidney function and cardiorenal physiology. It reduces the preload, afterload, reduction in LV wall stress, reduction in interstitial edema. So that's why maybe they used it in the preserved EF trial also. So the good thing is that this can maybe prevent the heart failure. So this is the important thing we have to see in future, that those patients, I would see that those patients who are obese and those patients who are having diabetes with obesity, suppose their LV functions are good, so maybe I would like to give them SGLT2 as a starter, or maybe very early I will institute, because what I feel is that obesity itself is a risk factor for heart failure, and these patients have multiple other risk factors, so it becomes a high risk factor for developing of heart failure. Or you should do maybe anti-pro BNP in these patients. If it is rising, maybe you must start maybe this drug, though we don't have guidelines, but I think sooner the guidelines are maybe going to come, because you have to think about the mechanisms of the drug and mechanism of the diabetic cardiomyopathy. So if you put these two together, then as far as if I'm a physician and I'm treating the diabetes patients, I think I am going to definitely put this drug as one of the first drugs, maybe if the patient can tolerate and he doesn't have, because you all know that it is a weight loss is also one of the side effects of this drug. I will not say side effects, because weight loss is a good for these obese patients. So I would say that this drug has a lot of promise in the future, and even the guidelines also, as he has told, are changing, and now we are going to consider SGLT2 and GLP-1 receptor agonist. And good thing about this SGLT2 inhibitors, it is a diuresis drug, and good thing is that it does not cause any hyponatremia. So some patients, they are getting into hyponatremia. So you can decrease the doses of diuretics and you can give this drug. So if scientifically and technically, if you want to use this drug, I think it's you can use it in a lot of such patients where they need some sort of a heart failure protection drug. So emperor heart failure studies now, obviously they have done, because DAPA HF study has also come. So they have done this study, and you can see that they have used this elevated anti-proBNP. So that's why I was telling that this is very important, anti-proBNP, because you can even predict the onset of heart failure in these patients who are even asymptomatic. So I would say and request my fellow endocrinologist that they must do the anti-proBNP in these patients, maybe after 6 months or any maybe 1 year, just to screen, because there is a trial which shows that you can predict the diabetic cardiomyopathy if you follow them with the anti-proBNP. There is a study, I have read it. So then this is a basically again emperor preserved and emperor reduced study was done, and this is just to tell you that how this study was done, and a lot of multicentric study. It's a large study, and it basically, this is basically in those patients, that whether the patients had benefit in reduced EF or preserved EF. The effects are on symptoms, exercise capacity, and patient reported outcomes are being investigated in this trial. And if you look at this is again just to look at that a large proportion expected to have an ejection fraction of less than 30%, and annual event rate is expected to be at least 15%, so that the predictability and the statistical significance of the trial is there. So what is the mechanism? Basically, what they have done is the screening period of up to 28 days, and then placebo, and post-treatment days of 30 days, and median follow-up is on 20 months. And they saw the primary endpoint at cardiovascular death or hospitalization for heart failure. So there are multiple proposed mechanism of action. Basically, SGLT2 inhibitors increase the fasting levels of ketone bodies, hypothesized to enhance the utilization of the sufficient metabolic fuel in the failing heart. However, experimentally, this has not been proven very consistently. But other thing which is more important is the cardiomyocyte injury and loss of the heart muscles by inhibiting the sodium hydrogen exchanger 1 in the myocardium, whose overactivity may lead to increase in intracellular calcium, sodium, which can impair cardiomyocyte function and viability. Also, it has been shown to inhibit the activation of calcium and calmodulin dependent kinase 2, which contributes to the activation of this thing. So ultimately, I think this may be the mechanism of this drug. So there are few results, top line results are there in patients of reduced EF with or without diabetes. That is basically time to first event of educated CV death or educated heart failure, and time frame up to 38 months, and composite primary endpoint time to first event of CV death. So meaningful addition to currently established treatment. So this is the basically NAGM cardiovascular renal outcomes. It is published there. So it is again telling you the same thing that three endpoint to be tested, and it reduced. This trial showed that empagliflozin is superior to placebo in improving heart failure outcomes on patients with symptomatic stable reduced EF patients on excellent baseline guideline directed medical therapy. These patients were on very good other medical therapy, like all the drugs were given, like maybe ARNI, ACE inhibitors, and other things. And even in the other trial, also they have seen that the patients they tolerated both the drugs, like there's ARNI and this drug. I think we are going back. So this slides just show that what is this trial. There are a lot of patients of class 2, class 3, class 4, and including criteria was heart failure hospitalization within 12 months, and anti-pro-BNP, anti-pro-BNP more than 600 if EF is less than 30, and more than 1000 if 31 to 35, and more than 2500 if EF is more than 35%. If there's an atrial fibrillation, then above thresholds are doubled because atrial fibrillation itself leads to high anti-pro-BNP. So obviously, this was the exclusion criteria: cardiomyopathy of infiltrative and others, severe valvular heart disease, because this interferes with the progression, and this very high mortality happens in severe valvular heart disease. So it's independent predictor. So we don't have to, in trials we don't have to, but otherwise you can definitely put your patients into, these patients will also get some benefit. There was white 70%, in Asian was also population was there, and European 36%, North America, Asia 13%, and mean EF was 27%, and diabetic were 50%, and 50% were non-diabetic. So this is an important thing to just see. Then the patients had basically angiotensin receptor and ARNI was 19%, and MRA 71%, beta blocker 94%, and there were patients on ICD and CRT. So the primary outcome was very good in these patients: 19.4 and 24.7 hazard ratio, good 0.75 and 0.001. So it is quite significant. Similarly, cardiovascular death was not much significant. Hazard ratio only 92, which is not very significant. But heart failure hospitalization was again significant because hazard ratio was quite good, 0.69. So I think the fundamental of this drug is that by decreasing the recurrent and the first heart failure, it also decreases maybe the overall some cardiovascular death which are attributable to heart failure. And renal function also were better. This is again very important. Hazard ratio was 0.5. Actually, I'm really excited because as a cardiologist, I'm very much worried about this cardiorenal syndrome. So if we can get some drug which helps us in cardiorenal syndrome, I think we are very happy. And Emperor reduced trial with empagliflozin will have a major impact on the management of patients with chronic heart failure and reduced EF, whether or not they have diabetes. This is important. And they should be added, and we should maybe be brave enough to now start these patients on this, and maybe build slowly. We may not give high dose drug. Maybe you start with 10 milligrams because if the patient is not diabetic, then you get your confidence and then you can go ahead with further. So again, this is just to show the same trial, empagliflozin trial, which again shows that composite endpoints and hospitalization, secondary outcomes, total number of heart failure was much less. Hazard ratios 0.70, and composite renal outcomes were also 0.50 hazard ratio, which is great. I would say that events per 100 patient year is 1.6 and versus 3.1. It's almost double. And death from any cause, again, not much difference, but definitely there was less. And onset of new diabetes in patients with pre-diabetes. This is also very interesting thing to note. That was also even less in these patients. So maybe again, I would say that those patients who have metabolic syndrome and those patients who have high anti-pro-BNP, maybe high sensitivity CRP level if they're high, maybe you can focus more on this patient because these are going to be patients who are going to be diabetic. So maybe actually you can prevent the diabetes also in these patients of obesity and heart failure. Again, this is again the same thing. I think we were repeating the same thing, time and again. So I think these are all the things already has been discussed with the Dr. Rajat, that adverse events were not much more than placebo. Rather, functioning and heart disorder and all was less only, and infection was more. Genital tract infection was more, but UTI was less. Not less, but I mean to say not significant. Hypoglycemia was comparable, so this is very important. And then there is a symptomatic hypotension. This is the most concerned with us, hypotension, symptomatic volume depletion. So these were all comparable, bone fractures, lower limb amputations. So these were not much significant because all these diabetic patients will have a lot of peripheral vascular disease also. So conclusion is that among patients receiving recommended therapy for heart failure, those in the EMPA group had a lower risk of cardiovascular death or hospitalization heart failure than those in placebo group, regardless of the presence or absence of the diabetes. So this is important. Secondary outcomes, total hospitalization were less than composite renal outcomes were also, less than all-cause mortality was less. New onset of diabetes already we have told, and HbA1c very good. Systolic blood pressure was more confirmed. Hypoglycemia was not much. The trial indicated it is superior to placebo in improving heart failure outcome among patients with symptomatic stable reduced EF on guideline after giving all these therapies, and primarily driven by reduction in heart failure hospitalization. This is very important, and there was also benefit in renal outcomes. So this is a similar like DAPA-HF trial for dapagliflozin, and even though it is introduced as diabetes management drug, but I think it is going to be having much more role in the future for heart failure management. And this is to be noted that the patients were on, even ARNI drug also. So if I think you are putting these patients on ARNI, and this cost can be an issue, there's no doubt, but I think in the future these drugs will going to have their cheaper because of their patent going off in few years. So these patients are going to have a lot of benefit. So mechanisms: adaptive cellular reprogramming, shift to ketone metabolism, reduced cardiac preload, inhibition of sodium hydrogen exchange, improved endothelial function, reduced cardiac fibrosis. So obviously few of them they have proven, but few of them are conjectures, speculated mechanisms. That is why it is known as speculated. It is still not clear because the drug started off as a diabetic drug, but now ending up with a heart failure, drug. So effect of empagliflozin as an add-on therapy on transtubular potassium concern gradient patients. This is further research is going on. Obviously, this drug, they have to search the mechanism and maybe further benefit of this drug in a diabetic patient or in heart failure patients. So there will be a lot of research on this drug. It is a very popular drug now. So maybe, thank you so much.
Thank you, sir, for a wonderful presentation. There is a question actually.
Yeah.
Yeah. For Dr. Rajat. Okay. The question is, sir, means there is a question from the audience. Actually, the question is, after this Emperor-HF trial, do you think empagliflozin can be treated at par with metformin in a diabetic patient? And what are the additional benefits it can incur, empagliflozin?
Come again. Actually, I did not get the question clearly.
Yes, actually, after this Emperor-HF trial, empagliflozin has shown good benefits actually. Okay, have shown the benefits. And the audience question is, do you think it can be treated as par with metformin? Empagliflozin can be treated as par with metformin now?
Metformin actually never showed benefit in heart failure. Only thing is it is neutral. It can be given in patients who are in stabilized heart failure state. It cannot be given in acute heart failure. So metformin is more of a cardio safe drug than the cardio benefit drug. In long term, it has shown cardiac benefit, but it did not show benefit in heart failure outcome. On the other hand, empagliflozin has shown significant reduction in hospitalization for heart failure in a diabetic as well as non-diabetic patient. Those who had pre-existing decreased ejection fraction, that is less than 40%. So these are absolutely two different drugs. Metformin remains the gold standard because of the years we have been using it and because of the cost of the molecule. These two are not comparable. But yes, EMPA is one of the now coming as the first add-on to metformin.
Okay. Dr. Anurag, the question is, can empagliflozin can be used in multiple severe risk factors?
Yes, definitely.
Yeah.
Anurag, Dr. Anurag, yeah. So
Yeah, you should. That's why in my lecture I told that if patient is having high risk outcomes, you're thinking that this patient has maybe slightly low EF or old coronary artery disease and diabetic patient, then you must use it. Maybe you should introduce this drug because it's going to have a lot of benefit. Patient, I told you that there are many indications of this drug because cardiac failure patient will ultimately go into renal failure. So you need to decrease the diuretic dependence.
okay.
And also, I think it's very important that you look at their electrolyte imbalance and all this. This drug does not cause any dyselectrolytemia. That's the beauty of this drug. So I really like this drug, and I'm using a lot in my lot of patients.
Okay, thank you. So there is no more question from the audience. So we are just concluding the session, sir. Okay.
Okay.
Thank you, Dr. Anurag, Dr. Rajat, for your wonderful presentation, sharing your experiences. And on behalf of Lupin, we thank you both and take care in this pandemic. We'll see you in the future meetings. Thank you, sir.
Thank you. Thank you,
Okay.
sir.
Javik and Dr. Rajat, my God bless.
Bye-bye.